We are live, ma'am.
Okay. A very good evening to all our dear students. And today is 18th of March, your most awaited date for NEET MDS, for which you have been preparing on since the past few months. And I'm sure all of you would have had a very wonderful exam. I am Dr. Ruchi Raj, your original guru for prosthodontics, and we are here within very few hours only for the recall session of your prosthodontics questions that were there in your NEET MDS 2024 exam, right? Now, the general overview or general impressions that we have received is that prosto questions were moderate to slightly tougher. And the general response or whatever information that I've received from students is that questions were long and lengthy. So it was difficult to actually follow and read them. Sometimes the question in itself is not very tough, but the question is very lengthy. So it's difficult to follow, read, understand, and hence attempt the correct answer of that question. That was the basic consensus about how Prostho was. Now, together, since it was slightly difficult to gather a recall of this subject, but we did it with the efficient team that we have. And let us begin with the first question. It is a number on a numerical based question. The question says that distance from the center of the incisive papilla in the maxilla to the central incisor. What is that distance? So if we take a maxillary arch like this, you have your incisive papilla present over here. It is asking that whatever incisors you have, central incisors here, what is the distance between them, the vertical distance that is present between them. Now, numerous studies have been conducted regarding this, and a lot of literature is present already. And the correct answer to this, given whatever information is provided, is answer A, that is 6 to 8 millimeters. So 6 to 8 millimeters is the correct answer over here. Now, the important piece of information which I wish to share with you is that a word center of incisive papilla has been mentioned. If it would have been the distal point of incisive papilla, again the answer changes. Similarly, I would want to give you one more extra point over here. From the center of the incisive papilla till the tip, or I would say from the center of the incisive papilla to the incisal edge. You can call it 6 to 8 millimeters. But if it is from the center of the incisive papilla to the labial surface of the central incisor, then the value here is 8 to 10 millimeters, which was option number B. So if, say, nothing has been mentioned, we consider that incisal edge has been taken into consideration over here, and hence we select the answer, which is option number A, 6 to 8 millimeters. It is a pretty easy question. It has been described in our textbooks very often. We have even covered it in our theory classes, in our recorded lectures and everything. So I'm sure this must be easy to answer for you. Now, second question is from implants, and we saw a lot of questions coming from implants this time. It was an image-based question, IBQ, showing 6 different steps of a particular procedure or a technique of implant. So here it shows which technique of implant is shown over here, and there were 6 different images. In the images, it could be very easily seen that there was a maxillary anterior tooth, then you are removing the tooth from its socket, fine, and you are retaining the labial fragment of the root over here while placing the implant. That was the image that was being shown. So what different technique is it? Is it socket shield technique? Is it a technique of just placing immediate implant? Is it some other technique? Now, obviously, options, there could be 1 or 2 options could be different, but our students very rightly jumped onto the answer because it was a very easy image-based questions, nicely covered in our theory and life classes. And the correct answer is socket shield technique. Now, here what happens is, why do we do this particular technique? In a socket shield technique in maxillary anteriors, most commonly we have seen whenever we place implants, the buccal bone or the labial bone, if it is thin, it over a period of time resorbs. When it resorbs, you can see grayish hue over here. You can see a grayish hue under the mucosa in long term, which is a complication of maxillary anterior immediate implants. So as to prevent this, what do? We section the root like this as shown over here. We section the root, and after sectioning, we are preserving the labial part. The labial part of the root is being preserved, and it has been preserved in the socket, and against it you have your endosteal implant immediately placed into the fresh extraction socket. So since by this technique it is called as socket shield technique, and a pretty easy image based question to appear for. Also, if you have any doubts and queries, we have a live chat box here on YouTube. You can definitely post your questions. Give me a moment and I'll just open the chat box. We'll see if you're posting any questions or queries. I can just simultaneously solve it for you. Any doubts? Right? So I have it in front of me. And if you have any questions, you can just post here in the chat box, and I am here. I can always solve your doubts, right? Now, next question is what? In a completely edentulous mandible. Also, if you have a better recall, just share it with us in the comment box and we can just cumulatively improve our questions here. Now, question number 3. In a completely edentulous mandible, the dentist decides to give overdenture with mini implants. The main crux point over here is mini implants. What do we do now? What is it used for? To achieve definitive prosthesis in a completely healed socket of less height and width, to achieve a temporary prosthesis in a completely healed socket, to achieve a definitive prosthesis in a recently extracted socket with sufficient height and width, and to achieve temporary prosthesis in a recently extracted socket. Now, the question here is that in a completely edentulous mandible, the dentist is going to give an overdenture with mini implants. Now, what happens is that usually when we have a resorbed ridge, it is always better to place 2 interforaminal implants, endosteal implants of sufficient width as well as length, and they can provide you decent support for your denture. In many cases, it is possible that the bone is not sufficient, and due to financial or medical reasons, the patient cannot undergo a long, tedious procedure of grafting. In these cases, we can definitely increase the number of mini implants and opt for mini implant supported overdenture. So whenever you have lesser quantity of bone, in that case, a mini implant supported overdenture is indicated. So considering these options over here, option number A, to achieve definitive prosthesis in a completely healed socket, but which is of less width and height, that can be the correct answer. Now, option number 4. Before that, I'll take a live query from a student who is saying, I think option number B is to achieve temporary prosthesis in completely healed socket of adequate depth and height, and A is to achieve in a completely healed socket. Now, mini implants, as far as what the literature says, is that it is indicated in a ridge that is of lesser height and width and lesser dimensions when you cannot place your complete normal endosteal implants. Mini implants are usually, they are less than 3 millimeters in diameter. So considering all of these points, option number A is the best option that we could come to. Question number 4, again from implants, the function of Crest module is what? Very important and a very simple question, but this is something that I have been stressing on very frequently in all of the sessions that we have been taking. Previous year questions don't get repeated straightforwardly. Usually questions come from previous year topics. And as we have said it again and again, you either will see a lot of image-based questions from implant components, or generally questions from implant components would come. And normally what you were seeing in the past exam was a photo of a hex driver, a photo of a torque wrench, or a healing abutment. This time now, you have a question pertaining to Crest module, which is a part of the implant, and you are being asked the function of it. And if you have studied components, I think you should have been able to easily answer this. You can put down the answer in the comment box if you know. So what is the function of a Crest module? Does it promote osseointegration? Is it for connection between implant and abutment? Does it allow gingival healing or is it for gingival healing? Well, the answer is none of the above. So here, as you can see, the correct answer for this is option number B. The Crest module serves as a connection between the implant and the prosthetic part, which could be your abutment or even your attachment. That is the simple, straightforward function of Crest module. Now, question number 5. What is Nesbit prosthesis? Some of you students were very confused here, but this is a straightforward previous year question. You should not be making mistake on this question. What is a Nesbit prosthesis? Is it an ear prosthesis or vital prosthesis, unilateral partial denture, or a guide plane in hemimandibulectomy patient's denture? Now, the correct answer here is it is a unilateral partial denture. This is a straightforward PYQ, and I give complete credits to whenever this question was first asked. The reason being that the name does not give away what it exactly could be. But if you have studied your previous year questions, which we repeatedly stress upon, we have even done a PYQ marathon earlier with all of our students so as to revise your PYQs. We have discussed Nesbit prosthesis, which is what? It is a unilateral partial denture. Mainly, it is a partial denture, a small denture that is used to restore missing tooth that are usually very less in number. Say 1 or 2 in number, not even more than that, or not very longer than that, right? So, that is question number 5. Should we take a halt to discuss some of your doubts? I see some of your doubts here. So, Charvi, could you be specific about what particular question you are saying that you have not seen? Okay, MDS aspirant. I think option number B is to achieve. Okay, I would just want to say any overdenture with mini implants is not a temporary prosthesis as such, but definitely you can consider it an intermediary prosthesis till the time patient can go for a normal diameter implant, or if the patient wants to go for a grafting in future and want to convert to a full arch prosthesis, right? But definitely not a temporary prosthesis in general, which is why I suggested option number A was the best answer. Sujoy is asking to explain question number 2. Okay, question number 2, Sujoy, it is a socket shield technique. Now, in maxillary anteriors, while placing implants, we have seen in freshly extracted sockets that labial bone or labial cortical bone is thin. And when the thickness is less, over a period of time, it resorbs. When it resorbs, now the threads of the implant are directly visible under the mucosa. And you will see a grayish hue visible over this region, right? Intraorally. So to avoid that, what do? Is we section the root of the tooth that is to be extracted. We section it into 2 parts, labially and palatally. We remove the palatal segment. We keep the labial segment as it is, and then we do our osteotomy. After doing the osteotomy, we will put our implant over there. So the implant labially will be in contact with your root portion of your labial part of the root portion of that particular tooth. And since that is present, the alveolar bone resorption does not occur. So this particular technique is called as a socket shield technique. I hope now you have understood, Sujat. Okay. Now coming to question number 6. Which major connector is not bulky but provides good support? Is it anteroposterior palatal bar? Is it a horseshoe-shaped connector? Is it anteroposterior palatal strap? And it is complete palate. Now, the question very specifically mentions 2 things. It should not be bulky and it should be able to provide good support. So, all of these options, while maintaining rigidity also, I don't prefer horseshoe. Complete palate has a lot of coverage. So out of these 2, my answer would be anteroposterior palatal strap. Probably one of the most versatile maxillary major connector. If you can see an anteroposterior palatal strap, it will even have your L-beam effect that will give you additional rigidity. So AP strap would be my answer for this question. Pretty easy and a straightforward question. Also, we'll have a look at our suggestions or doubts that students are asking. No, I would just like to clarify, dear students, Nesbit prosthesis is a unilateral partial denture. It is a small denture that is made for one or two missing teeth. That is the correct answer for it. That is, in fact, a previous year question. So I suggest you should not get confused over it. Question number 7, again from major connectors. Now, two questions from major connectors. In a patient with periodontally compromised anteriors, the choice of major connectors is what? Labial bar, sublingual bar, lingual bar, and a lingo plate. A very pretty straightforward question. Lingo plate is the answer. The reason is that lingo plate has a apron or sheath of metal anteriorly, which will allow you to add more teeth anteriorly when they are extracted. When anterior teeth get extracted or when they are lost, you cannot or you should not be replacing the complete prosthesis. You just need to add it over there, right? Okay. So there is a doubt whether bar is bulky or strap is bulky. A bar is definitely bulkier rather than a strap. So that is why the answer is AP strap. Again, Amruta, same for your question. Answer is AP strap. The reason being the question very specifically mentioned it should not be bulky. And the main complaint that we have with AP bar is patient has a sense of bulkiness in the mouth, plus there is an additional thickness to it. Whereas AP strap is quite easy and comfortable and is of lesser thickness also. Sublingual bar cannot be the answer over here. The reason is that when specifically it has been mentioned in periodontally compromised anteriors, you need a sheath or apron of metal where newer teeth can be attached. Sublingual bar goes way deep into the sulcus. Lingual bar also lies in the sulcus. There is no connection where you can add up new teeth. If you read about advantages of lingo plate given very clearly in McCracken's, there is a sheath or apron of metal like this. Say fine. If it is an interrupted lingo plate, it goes like this. Or there's just a sheath or apron of metal where you can add new teeth, which is why lingo plate would be your correct answer. U-shaped horseshoe shaped connector, like the question is being asked, it is not bulky and it can be used. No, the U-shaped connector cannot be used because it does not provide rigidity, which is the primary function of any major connector. In a U-shape or a horseshoe shaped connector, there is flexibility, which is why it cannot be used. So overall of all of these options, AP strap is the best answer. Again, Mohammed is asking why not sublingual bar when the patient is periodontally compromised? Because we want to add new teeth in future in periodontally compromised anteriors. By giving a sheath or apron of metal, you are bracing the teeth. Secondly, you are providing a provision for adding new teeth in future. For both of these reasons, very straightforward, 100% the answer is lingo plate without a doubt. Coming to question number 8, in a complete denture patient, it was stated that upper and lower occlusal rims are present in a patient's mouth. And on mandibular protrusion, a triangular space is visible posteriorly. What is this phenomenon called? And the answer here is Christenson's phenomenon. Now, please help me with the recall of this question if you remember any other options here. And I will make you understand what exactly the theory around it is that. Whenever we do protrusion, there is disocclusion between the posterior teeth. That phenomenon is called Christenson's phenomenon. This particular phenomenon is not desirable in your complete denture because it will lead to loss of stability. So if they are talking about the gap between the occlusal rims posteriorly on protrusion, that is in a way showing Christenson's phenomenon in that particular complete denture. But again, since it was a very straightforward question, students and everyone here just remember it very easily that Christenson's was the answer. But if you do remember other options, please definitely let us know. Christenson's is not seen in denture patients, but it is asking during formation of occlusal rims during jaw relation. So this is during the step of jaw relations. Definitely the space needs to be corrected during jaw relations. So this is not in a denture. They're talking during jaw relation process, right? Now, question number 9. This is a question that was very much discussed while preparing this presentation because it was a long, lengthy question. A cartwheel-like musculature that has role in border molding and neutral zone mechanism in complete denture. What is that? Now, typically here, what we are making is that they are asking about muscles that are involved in neutral zone and border molding. And it comprises of mainly buccinator, masseter, your modulus, right? Now, if we see at the options over here, this is your modulus, fine. This also comprises of your modulus. So then what do we select, right? These cannot be our answers. And definitely, if you have better recall of these questions, please put in the options. But if this is the stated option over here in the exam, my correct answer would be option number C because it has buccinator and masseter. The most important muscle for neutral zone is definitely buccinator masseter. That should be there. By that, I'm eliminating option number A and D. Now, superior constrictor is not involved in neutral zone, by which I'm eliminating option number B here. Plus, option number C keeps muscle of a modulus, which is levator anguli oris also, buccinator as well as masseter. The better answer or option should have incorporated orbicularis oris. Right? That is also there. Now we'll take up some doubts from our chat box. And fine. So question number 9 here, students. Do you have any suggestions for me over here? Fine. So question number 10. A hydroxyapatite coated implant is preferred in comparison to a titanium machined implant in extraction site of upper left second molar in all of these cases except what? So again, this is a previous year question. In what situation where you will prefer a hydroxyapatite coated implant in comparison to a titanium machined implant in an extraction site of an upper left second molar? In all of these cases, except what? The correct answer would be a type 1 bone. In a type 1 bone, you do not require that. Otherwise, for fresh extraction sites or a newly grafted sites or sites that require greater bone implant contact, you definitely require a hydroxyapatite coated implant. So answer here is option number B. I agree completely with you, Shruti, and I am also slightly skeptical of the options over here. What could be the correct options and what I could receive the best recall that I have mentioned here. But if you do have the complete recall, please mention it with the complete questions rather than writing only the options over here. So it should be better for us to solve. I can definitely solve all of your questions in the chat box. So even after the session is over, please put the complete question with the options in the chat box, and that should be easy for all of us to understand as well as get to a better answer. Now, question number 11. A 39-year-old with endodontically treated upper first molar. Crown height was less. So, finish line is plain subgingivally. Advantages of placing this subgingivally are what? To place it on hard enamel, difficulty in assessing restoration and recall visit, to place it in an aesthetic zone, or any fourth other option. Now, the correct answer here is place it on hard enamel. Whenever you have lesser crown height, to achieve more height of the restoration, we can go subgingivally. And if we have an endodontically treated tooth, it is always known that we never place the margins on a restoration. We go subgingivally so that we place the margins on the hard enamel tooth that is always there. Even if you receive a feather edge margin preparation over there, but we will always place it onto hard enamel only. So of all of these options, I think the best option was option number 11. Sorry, option number A for question number 11. Disadvantages of HTV over RTV for maxillofacial silicones were what? Does it have poor color stability, opaqueness, lower shelf life, and a low thermal stability? Now, we have seen that room temperature vulcanizing silicone is used quite frequently for fabrication of your maxillofacial prosthesis. And HTV is also sometimes used, right? Now, HTV has a lot of good properties, but the main disadvantage is that it is quite opaque and lifeless in comparison to RTV. So the correct answer here is opaqueness. It definitely has good shelf life, thermal stability, and color stability also. But because of its opaque nature, we do not prefer HTV in comparison to your RTV. So that is it. And the last and final question from Prosto is, position of mental foramen in old male edentulous patient would be what? Does it rise closer to the superior border of mandible? Is it closer to the inferior border? Is it between them, or is it none of the above? Now the answer here is closer to superior border. The reason for it is that, say, this is the position of mental foramen. When resorption of alveolar bone and bone overlying it happens, it is coming close to the superior border of mandible. These are age changes of mandible. Again, very important topic and very important question that has been asked very repeatedly in complete denture. So a very straightforward question is option number A, closer to superior border. Right? Now, I'll start up with your query here. Now, Danish is saying question 12 had poor mechanical properties. Despite that, I think, Danish, that is not the correct answer. The reason being that mechanical properties of HTV are very good. It has good color stability. It has good shelf life, thermal stability. So definitely that is not there. I'll take care of all of the other suggestions that all of you students have mentioned. And I'll request all of you students one thing. Together, you and I, we can get over all of our prosto doubts. Sometimes it does happen that questions are slightly tricky, difficult, or something that is difficult to recall. But at the end of the day, we need to solve it even for our upcoming INICET exam, which I'm sure all of you might be appearing for, right? So what I suggest all of you, if you recall a question better, just please put the complete question with its option in the chat box after the session gets over, and I can come back and definitely solve it, and we can come with a better recall version of this paper before your INICET exam. And definitely, I'm sure all of you are joining for the INICET power plan also. So when you receive and when you join us for the power plan, you would be able to see a better recall of this paper, right? This time, the general feedback was that prosto questions were different or maybe tough. So still, we try to collect a lot of these questions within the few hours that we had after the exam. And I'm sure that it would be helpful for all of you students also. With this, I would just want to briefly tell you something about the Advanced Plus plan that is there. The pre-bookings of it are open, and there are a lot of pre-recorded videos with 600 plus hours of high quality with all of the 19 subjects. Extensive QBank also has been verified and solved by all of our mentors. You have competitive test series also, and you have a lot of clinical videos also over there, right? Apart from that, whatever live class we take, you have very good hard copy notes of the same live classes delivered to you for all of the 19 subjects, right? Plus, you have access to all the revision videos and daily mentorship with Dr. Himani, right? So this is the pre-booking for your Advanced Plus plan. You all can refer to it, and if you wish, you can definitely join for it. Connect with the team, and they will help you to get access to it, or purchase the plan if you need. We would also come up with the INI Power Plus plan that should help you tackle the upcoming INI exam also. With this, I, Dr. Ruchi Raj, would end up this particular session. It was a lovely recall session, and we put in probably hours just to understand what the questions were. Because the initial few minutes, all I was getting from our students was the questions are very tough or very different. And I was hoping I probably would not even get to 10 questions. I don't know, but we were still able to get 12 questions here. And one or two options, if they are here and there, please put it as suggestions in the chat box. I'll take them and I'll try and come up with a better paper before your next exam. Any doubts, any queries, any suggestions, feel free to always put up in the chat box. This is me, Dr. Ruchi Raj, ending this particular session here. I wish all the best for all of you students for your ranks in this particular exam.